All right. So a little bit about myself my name is Juan Li. I'm a PhD in engineering, and my background is math and applied math and engineering and statistics. So like right now, I'm a postdoc fellow and a methodologist working in the Ottawa Hospital Research Institute. And this project is like a team project by me and three other PIs. So all the three PIs are either neurologists and research scientists or movement disorder specialists and epidemiologists. So this project are a work of all experience from different disciplines around Parkinson's disease. And also this work was sponsored by Michael J. Fox Foundation and Parkinson Canada. And it was my great honor. Like I received the basic research fellowship last year from Parkinson Canada. And I think it's funded by PC from the British Columbia section of the PC. So thank you very much for your support, and like all your support and generosity will make this project moving along. So like my talk today will talk about the first evaluation of the PREDICT score, and I will explain what's the details about the score in the later slides. And this score was designed to predict the high risk of having Parkinson's disease in the still healthy people. But for this evaluation today, it's not about prediction yet. It's more about discrimination. It's like for a group of PD patients and a group of healthy people, will the score can tell us if that's like person has PD or doesn't have PD. So let's go to the sorry. All right. So a little bit about the hypothesis and goals about this model. So you can see the I'll just have the pointer here. So you can see the figure here. This is basically a disease trajectory plot. It's a systematic plot that we think for as people getting older, their risk of having PD are like increasing. So for most people, like for healthy subjects, their risk will remain low through their lifetime. And for like for here, the IPD is for typical PD. So for most PD patients, they will have the like motor onset at their age of around 60 or so. And so like as they're getting older, they will have some like they will change from the normal states to have some preclinical traits and have some prodromal maybe before the motor onset, they may have some prodromal symptoms and until they reach the criteria for being diagnosed with PD. And there's some rare case of the young onset PD that they may get diagnosed with PD as age before 50 or around 40. And for most people that diagnosis with young onset PD is more likely to be genetically related. And also okay, so sorry. So for our project, we want to identify people at this stage or at this stage, i.e., before their disease onset. If we can find people as clinical and prodromal stage, it may help the doctors will include them into some clinical trials, or maybe there's some like prevention or intervention procedures can help them to like postpone their disease onset. Because at the stage when they diagnose with PD, maybe like there will be 60 or 80% of cell loss about to produce dopamines. So at this stage, sorry, I'm a little bit nervous, so sorry. At this stage, the disease cure may be quite difficult because they already have a has a high level of cell loss. So it will be identical to find people at the earlier stage possible, and then to have some prevention and intervention. So here is what the PREDICT stands for. So we hypothesize that the risk of developing, I'll use this. So the risk of developing PD is a product of five factors. So here is the E and D and I and G and T. So you can see for details, the E is for environmental factors like environmental exposures and some something you will interact with the environment. And D is for DNA genetics. And for most people, if you don't really know your genetic risk, you can have a surrogate as a family history. And then for I is for initiation of tissue changes. So this is most for the interaction, like a result of the interaction between factor E and factor D. And then for gender is for because we know like the males like the men have a higher risk compared with women to have PD. And T is for age, is like for people getting older, is more likely they will have PD. And I just saw Wendy ask about which cell are lost. So here, okay. So because like my background is mathematics, so this is just what I learned from my PIs and reading the some papers. It is estimated that people with PD have lost 60% to 80% or more of the neurons that produce dopamine by the time motor symptoms appear. So it is very important to identify people at the early stage before they have this amount of cell loss. So I will go to the details of each factors in the next, in the later slides. And here is like our hypothesis. So and also this is based on the experience of our PIs and other neurologists, and is also based on a lot of literatures about meta-analysis that they gather different cohort and data sets, and they say, okay, certain variables or certain factors are associated with higher or lower risk. So this is basically a result of experience and different meta-analysis. And also, like from my talk with other patients and family members before, I heard some stories about how they get diagnosed. And it occurs to me that family doctors actually plays a really big role for people because if the family doctors, they have experience, like they have seen or dealing with Parkinson's disease before, they can like notice some early signs and they can refer their patients to see a specialist earlier. And some doctors, if they haven't come across this disease in their career before, it's very easy for them to miss those signs, and maybe until a later stage they realize, okay, there's something wrong with the motor, maybe we refer you to see a specialist. So we also think this model, because this model a strong effect of this model is like it doesn't include any motor aspect in this model, because we want to find people before their motor symptoms. So all these are like either genetic or environmental exposures or some non-motor symptoms or aspects of the disease. So we also want to, it's not really like we educate family doctors, but we want to have a small tool for the GPs and see this is a list of risk we think maybe associated with higher risk. And if you see your patients have like certain concerns or have some risk factors, we will be able to refer them to see the specialist earlier. So we think this model, one thing is for identify people and for predict, and also we want them to help diagnosis as well. So this slide is about two cohorts we are using in this talks today. So they called DeNoPa and PPMI. So DeNoPa is called de novo, it's like newly diagnosed. It's de novo Parkinson study, and PPMI is for progression Parkinson markers initiative, I think. So the DeNoPa is a single center study in Germany, and it has 159 PD patients, and 110 healthy controls. And the healthy controls are age and sex matched with the disease cohort. And for PPMI, it's a larger cohort. It's an international cohort in United States and Canada. And I think it also have a European site as well. And it has 430 Parkinson's disease patients and 199 healthy controls. And also the healthy controls are age and sex matched of cohorts. So you can see in this table here about the gender distribution across cohort and across the disease group, and also their age distribution. So in both cohorts, they have the similar characteristics about the participants. So about like 2/3 of the participants are male and 1/3 are female, and the age distribution are mostly around say 50, between 50 and 80, I think. So these two cohorts compare a lot of similarities, although they have some difference about what wearables they have collected. So this, for this, this is the list of wearables that we are interested in for each factor, and I will go to a more detailed description of each wearables. And before I go to details, I just want to explain the measurement I reported here. So here, this is like, for example, from metal exposure, like the 10 is for inside PD patients. 10 people report they have been exposed to some metal related. It's more like they work in a metal related fields, and this is the percentage. And here it's for healthy people, like how many people have exposed and what's the percentage. And the odds ratio is a measurement of like what's the association between this wearable and the risk. So if the odds ratio is larger than 1, it means it's associated with higher risk. And if it's below 1, it means it's associated with lower risk. And here is the confidence interval. And so this is the same for the PPMI cohort as well. And the AUC here is for, I will go to AUC later because this is a quite important measurement for model assessment. But here, a rule of thumb is for AUC, like it's, I think it's generally larger than 0.5, and it's as closer to 1, it means it's more accurate to distinguish PD with, people with PD from those without it. And for this figure here, so you can see this vertical gray line here is actually indicates odds ratio equal to 1. So for all the points like larger than 1 means these variables are associated with higher risk, and if it's lower than 1 means it is associated with lower risk. So I may be a little bit too fast, and if you find something you don't really quite understand or follow yet, you can please feel free to have a question. I will just re-explain those concepts. I know this might be a lot for people like not really familiar with this kind of model, but I want to give you a more intuitively understanding of all this concept. So let's go to the variables like for details. Okay, so first of all, we go into the environmental factors. So here we list 1, 2, 3, 4, 5, 6, 7 variables like we think are environmental factors. But here from metal exposure, pesticide, head trauma, constipation, and olfaction change, the first 5 are associated with higher risk, we think. And for smoking and caffeine intake, the data suggests they're associated with lower risk. So here for pesticide and farm exposure is not for a single event. It's more about the continuous exposure, mostly associated with your occupation and job. And for head trauma, it will depends on the severity of the head trauma, and also have you lost conscious when you experience this head trauma. And then for constipation, it's like we noticed that for PD patients, it's a higher percentage of people have the problem with constipation compared with the healthy people. And olfaction change is actually your sense of smell. I think most of the patients in the office, doctor may ask you if you recently think like your sense of smell or taste are different, or like something you enjoy eating before and now you feel it's a little bit bland. That's maybe an indicator like you have reduced the sense of smell. Actually, sense of smell is a really high indicator that you may on early stage of something. And although there's other neurological disease can also have this kind of treat before the disease diagnosis. And for smoking and caffeine intake, there's a little bit debate and argument in the fields because some people say they are associated with lower risk because they can help you for your for like your inside like environment, and that may that may explain why they show protection. But other scientists say it's more about personality traits than actual protective effect. That means they think like some scientists thinking like for PD patients, they may share some sort of personality trait, and for that they may choose not, like they are more likely to be not smoking or drinking coffee and tea. So like right now we only see the data to show some association, but there's no causality yet. So it's not say we are like encouraging people to smoke so you can have a low risk of PD. Like that's not about it, but it's just like for PD patients, there's a lower percentage of smokers compared with other groups. So later for factor D, we have family history of PD and also genetic risk score. So here, because like right now, more and more people, they are having their DNA tested, like use the 23andMe or other companies' product. And so more and more people, they know more about their genetic risk. And if you don't have your DNA tested yet, like the doctors can use the family history as a surrogate. So if you have some family members, especially like your first-degree relatives, like your mother, father, children, or siblings, that might be a strong risk factors for the individual to having PD. So here for factor I, we have two biomarkers. This CSF means spinal fluids. So for participants in these two cohorts, they have been doing the lumbar puncture procedures to have their spinal fluids tested. And it has been found that the alpha-synuclein and tau in the spinal fluids like is lower for the PD patients compared with healthy people. And then for there's other three is non-motor like non-motor aspect of PD is like depression, anxiety, and RBD. So RBD is the REM sleep behavior. It's like some people will act out their dreams, and they may just like wave their arms or even hurt their bed partners. So this is some aspects of the RBD. And then we also have the male sex and older age for the risk factors. Although I have to say, because PPMI and DeNoPa are two age and sex matched cohort, that means they match the age and sex for the healthy people to the PD patients. So the accurate influence of sex and age are not really really represented in these two cohorts. Okay, so here is an example about how we calculate the PREDICT score, because I know all the earlier introductions are a little bit too abstract. So here I will use two examples to go through how the score was calculated. So here we have two examples, subject 1 and subject 2. And we will go through each variables in the list, and I can show you how their score was calculated. So here for so this slides here only for factor E for their environmental exposures. So the subject I, he or she didn't work in the metal-related fields, or they never exposed to heavy metal poisoning. But this person has worked in agriculture for a certain amount of time. So here is a higher risk, and we assign 0.2.5 to his or her score. And then, although this person haven't exposed to pesticide or herbicide, and then he or she doesn't have head trauma, constipation, and the sense of smell is normal. So like there's no risk for this for wearables. And this person has smoked for he or she stopped smoking now, but like he or she was smoke for between 11 to 19 years. So we have a like negative score here because like smoking we see associated with lower risk. And then for caffeine is like this person drink coffee or tea regularly and is more than 2 cups a day. So all in all, and we sum all these scores, and they have a negative 0.125 for this subject. Well, for subject 2, although he or she doesn't have any exposures, and he or she doesn't have head trauma, but this person does have constipation problem. And also for one, it means the smell test score was so low, we think like he's lost his sense of smell. And then for smoking, he briefly smoking like below 10 years. So there's a little bit protective factors, but not a lot. But he also drink coffee or tea over 2 cups a day. So because the loss of sense of smell and constipation, this risk score is much higher than subject 1. So this score is above 1. So for next slides is for factor D and I, still same subject 1 and subject 2. And subject 1 doesn't have any family members of PD patients, and subject 2 have the second degree is like grandparents or grandchildren or aunt or uncle, like some family members have Parkinson's disease. So here the risk score 0.2.5. And then and then for factor I, the first subject, he doesn't have any wearables associated with factor I. And the subject 2, like his or her level of alpha-synuclein and tau in the spinal fluid is lower than cut value. So this is associated with high risk. And then so his higher risk, his score on factor I will be 0.5. And we add all the score together, and we times the factor for, because they both male, so their score will times 1.2 and then times their age. So we have the total score for subject 1 is minus 8.55, and subject 2 score is much higher, it's over 169. So, and also because we already know if they are PD patients or healthy control, and like here is what they are in the group. So this is just an example of how the score was calculated. It's basically based on your responses to each question, and based on if it's yes or no or what level it is, we'll assign a score to that variables, and we will have a sum of total score of all the responses. Oh, okay. So here, this is about for each individual how we calculate their scores. And for evaluate the performance of the total model, we have to see a big picture. And so before I go into, I show you the results of this particular model, how they performance. There's some concept I have to introduce you, like for how to assess the model performance. And again, there's might be a little bit math in here, and I will use figures so I can give you intuitively to help you intuitively understand this concept. And again, if you find like I'm talking too fast or there's certain questions, just ask question anytime, and I will just re-explain the concept. So here is for Wikipedia, like how we define the model sensitivity and model specificity. So we'll in order to help you understanding, I will just make this more closer to our talk today. So here for the true condition, because we already know is the PD group, the PD patients and healthy controls. And the predict condition is because we have the score for each individual, and we will come to we will come up with a threshold, and the model will think anyone like the score is above the threshold will think you are a PD patient, and if your score is lower than the threshold, we think you're a healthy people. And then compare with the true condition we already know, we can see if like the model think you are having PD and you really are a PD patient, it means it's a true positive. And if you are a healthy control and your score is lower than threshold, it's a true negative. And there's also two types of error. If you're healthy, but your score for some reason are really high and higher than the threshold, so the model think you are PD patients. That's a type 1 error. It's called false positive. And or if you really are a PD patient, but for some reason your risk score is really lower than the threshold, and this is called false negative. So with this table in mind, the sensitivity is the true positive rate over the total PD patients. In other words, is out of the total PD patients, what's the proportion that the model find is right. So it's like what's the proportion of you really have PD and the model thinks you have PD as well. And for specificity is the other hand, if you are healthy people, you don't have PD, and what's the proportion like your score is lower than the threshold. So these are the concepts about sensitivity and specificity. But all this is about one particular threshold. Oh, sorry. And the threshold can change, right? So if we move here, this vertical black bar is a threshold. If we move the threshold from 0 to 205, the model will give you different set of sensitivity and specificity. So for example, here, this is for healthy people, and this is for sorry. So this plot here is for healthy people, and this plot here is for the PD patients. And you can refer to the table here for different colors. So the bright red is for true positive, and the bright blue is for true negative, and the salmon pink color is for false positive. It means you're healthy, but the model thinks you have PD, and the light blue is for false negative, as reflected in the figure here. So for this certain bar, we can see the number of people that's in each category, and we can calculate the sensitivity and specificity, and reflect on this curve. Like this bright dot here is the pair of specificity and the pair and the sensitivity. So this dot here is corresponding to this threshold here. So if we move the threshold a little bit higher, you can see the region for like these 4 regions will change, and the sensitivity and specificity will change as well. So it's the dot here in this curve, and we can increase threshold even higher, and there's another pair of sensitivity and specificity. So we can see here, as the cut value or threshold moving from low to high, specificity will increase with the cost of sensitivity. Because if you set the cut value is really low, basically the model think everyone is a PD, everyone are PD patients. So of course, if you really are a PD patient, the model is right. But that means your sensitivity is really high. But for specificity, it's like for the model think every healthy people are PD patients as well. That's where the model make a mistake. And if the threshold is really high, it's quite the opposite. It's like the model think everyone is healthy. So for healthy people, that's right. But for PD patients, the model make a mistake. So we want to find a trade-off between the sensitivity and specificity. That's when we define the optimal threshold is the maximum sum of sensitivity and specificity. So with all those, there's another concept I need to explain. So here is AUC. I briefly talked about AUC before in the first plot. And here the AUC is the total performance of the model. As you can see earlier, as the threshold change, the change of sensitivity and specificity point will constructed a curve. So area under that curve, that curve is called ROC curve. And so area under this ROC curve is a measurement of how this model performed. And so here, this diagonal line is called chance line. It's a 50-50 chance line. It's just we toss a coin and say if you're healthy or not. And if the AUC is close to 100, it means this is perfect model. It can just tell who has PD and who hasn't with no mistake. And this is like is a more realistic situation where it makes some mistake, but most of the time it will be right. And if the AUC is equal to 50-50, means this model cannot do better than toss a coin. Means you have to do a serious job to improve your model. Okay, so here Wendy asked another really good question about what is the length of study, and how do you know the healthy controls are not just pre-diagnosis? This is a really good question, and actually for DeNoPa and PPMI, they both follow patients for a period of time, and I think for their healthy controls, no one converged to be diagnosed with PD until now. And I think for their inclusion and exclusion criteria, they really they want to find like really say healthy. It's not healthy in a sense like they will not develop PD in like a short period of time. Although there might be some people like if you follow them long enough may develop PD, but like at the moment like no one converged to PD yet. But this is a really good question, and they may cause some misunderstanding by the model. Think like someone like if they're say appear to be healthy now, if their risk is really high, it means like it's actually we may want to follow them even longer to say if they eventually will have PD. I hope I answer your questions. And then, okay, for next slide, I'll just show you the results. So, okay, so this curve is the ROC curve I just present. So for here, the AUC is 0.85. Means this model is actually doing quite good to distinguish PD patients and healthy control. And also you can see here. So here the first plot on the right is for the score density, and the bluish color is for healthy controls, and the pink is for PD patients, and the purplish is the overlap between healthy control and PD patients. But we can see generally, and also the same for the box plot here. And we can see generally the PD patients, they have a higher score compared with the am I right? Like PD patients have a higher score compared with the healthy controls. That's why this model can help us to separate PD patients and healthy people. And this red vertical lines and also this red horizontal lines are indicating the threshold we have right now is for the sensitivity and specificity pair reported here. So it means for the threshold we have now is 78.19, and the models think everyone whose score is higher than this the model thinks you are PD patients, and if you lower, the model thinks you are healthy controls. And we use that to generate this ROC curve. The take-home message for this model is like for DeNoPa subjects, this AUC can separate PD patients and healthy controls with around 85% accuracy. And the next slide here is for PPMI subjects. You can see here the AUC is 0.88, is around the same level of performance and even better than in DeNoPa. And also we can see the distinction of the score density between healthy people and PD patients. For box plot here, you may look even clearer, like most of the PD patients, their score are higher than most of the healthy controls. So here and the last slides are for two cohorts separately. We separate because first of all, because their list of variables are slightly different. For example, PPMI, like they didn't ask people about their environmental exposure. So like these two cohorts are not entirely similar. But also we noticed because another thing we noticed is like both cohorts, the participants share a lot of same trait and same characteristics. So we think it's reasonable to combine these two cohorts together. So we have another shared model here. So the shared model is because we know they have a slightly different list of variables. So here we only have the variables that are shared by both cohorts, and we come up with the score here. And you can see here the all is for two cohorts combined, and DeNoPa and PPMI are for the separate specific cohort, and all their performance are really similar. You can also see from the figure from the curve here, because all the curves are quite close together. So this actually is a really good sign, is a assuring sign to us, because often a mathematical model, especially if it's a machine learning model, it might be cohort specific, in the sense that it can only performance good in one cohort and not necessarily on the other. But the fact here that the model have a similar performance across two cohorts and even combined tell us like this model is quite robust across different populations, and also this models have captured some shared or some important risk factors for developing Parkinson's disease. So this is for our results now. And like we all preparing these results for published in a paper. And if you have any questions, you can just ask in the sidebar. So here is for what we are doing now, and what we will do in the future work. So we are about to finish the aim 1 here, is to further validate or evaluate the PREDICT scores discriminative performance. And the next stage will to assess the model's predictive power. So for predictive is like there's some cohorts that is perfect for this work, because for example, there's one cohort called PARS. It's like they follow a group of people, they have lost their sense of smell, and they follow them for, I think it's 7 to 8 years, and like a proportion of them like eventually develop PD. So for this kind of cohort, it's perfect for us to test the model's predictive power. It's like we have a group of people, like we don't know who will have PD or who will not, and we just follow long enough to see like who will like eventually convert it to PD, and this will help us to test the model's predictive power. And the other aim is for calibrate the model. For calibrate is because right now all we use are clinical trials and cohorts. So like the researchers and scientists, they just recruit a group of people, either PD patients or healthy controls. But all the risk reflected in these cohorts may not the same as in the general population. Say if we have a survey in Ontario or in BC, and you may find not, so, not like, because like right now the cohorts we have a group of people lost their sense of smell, for example. But when we go to the whole BC, maybe there's not so many people have lost their sense of smell. So it means in the whole population, like each wearables, their association with risk will not at the same as the cohort here. So that's why we need the population-based data to calibrate this model. And then we want to develop an online calculator or questionnaire, so it can either to be used in the GP's office, like I talked earlier. If the GP can based on the questionnaire, they know, okay, there's certain risk associated with PD, and if they notice some early signs of their patients, they may help them to calculate their risk score, and even like refer them to see the specialist if their risk is really high. And also it can be used as like at-home questionnaire. It's like online tools. I don't know if you know about like Fox Insight research. It's kind of like platform that you can register, and there's a list of questions you can answer and have your risk calculated. It's also a kind of application and implement we are looking at. So this is basically what we're doing right now and what we will going to do in the next steps. Also, again, like thank you for your support and sponsored. That's how we can proceed with this project. And then the last slide is for acknowledgement of all my PIs and all my colleagues in the Schlossmacher lab and our collaborators from cohort and from OHRI. And the last is our sponsors, is Parkinson Canada and Michael J. Fox Foundation. Yes. I think that's all for my talk today. And if you have any questions, I think we can go to the Q&A session now.
Perfect. Thank you so much, Dr. Li. That was super interesting. So like Dr. Li said, if you have any questions, please feel free to share them in the chat box. I will start us off with one. Seeing as this research is ongoing, if people want to participate, are you still looking for participants? And if so, how can people get more information?
Thank you, Amy. This is actually exactly the questions I want to address like for this kind of talk. So like right now for OHRI and for our group, we don't have active clinical trial yet because like there are still several steps that, like I said, for like calibrate and to make the model like really robust before we have it on the field test. So right now we don't have a trial yet. But if you're really interested in this kind of research, I think we will have a clinical trial in like following years, and I will update you on that. And also, there's another active similar research for Michael J. Fox Foundation. It's called Fox Insight, and that's when people can register and answer. Like I think they have I have to say 10 to 20 different questionnaires about different aspects. So I think right now is like, I think if you go to websites right now, if you want to participate in this kind of study.
Okay, great. Thank you. Well, it doesn't look like we have any questions coming in. Thank you again so much for taking the time to put the presentation together and for taking the time to speak this morning. I do recognize it. I hope you all have a great day and have some time to enjoy the nice weather we're having. Take care, everyone.
Thank you very much.